Hi, everybody. My name is Tina Layton. I'm the dietitian and diabetes educator at New Hampshire Healthy Families. And my role is I'm a health coach. And so I'm just going to go through everything and just let you know what I do, but also give you kind of an idea of what I would imagine the community health workers can do. So let me just share my screen. So the title of this is Community-Based Diabetes Health Education, but also Nutrition. My degree is, I'm a registered dietitian, and recently our diabetes educator title changed from CDE to CDCES, and that just stands for Certified Diabetes Care and Education Specialist. I may have to take a drink, my throat's getting a little scratchy. So I have no conflicts of interest with this presentation, with the information. So scope and practice of a dietitian or a diabetes educator dietitian, we guide and support a person with multiple diet restrictions to make meal planning easier, such as heart disease and gastrointestinal conditions. A lot of times a person with diabetes will have more than one diet restriction and limitation regarding their food. So they could have things like hypertension, high cholesterol, GERD, gastroesophageal reflux disease, IBS, they could have gout, they could have lactose intolerance, they could have so many things to make their basic diabetes diet a little bit more tricky. So I can add a little bit of information and a little bit of help with that. Mostly what I do is I help people manage their diabetes better with lifestyle changes, nutrition advice, exercise advice, promoting medication adherence and blood sugar monitoring. And I do assist medical professionals with appropriate nutrition and diabetes information and advice. So there's so much out in the world today with, in the media, with magazines and internet and things that people see with the latest diet, and the latest diet is not always appropriate for a person, especially an older person with comorbidities and with diabetes and heart disease. So I try to educate medical professionals as well and the nurses that I work with. And there's been a lot of great questions coming in regarding the latest and greatest diets and strategies to make their blood sugar better, or even people have heard claims that they can even make their diabetes go away if you do certain things. So I try to dispel those myths and back up the facts. So that's pretty much what I do. The role that I see of a community support worker or a health worker would be to educate the patient and their families on the importance of lifestyle changes, adherence to medication regimes, and prescribed treatments by their provider, so they're supporting that patient's plan with their healthcare plan. And helping patients navigate the healthcare system, so if they need help calling their doctor's office or advocating for them. So sometimes patients don't feel comfortable expressing themselves or feeling comfortable with their provider. So maybe a health worker might encourage them to ask questions, encourage them to relax and take deep breaths, and to even write down their questions before they go to the doctor, things that might just help the visit go a little bit more smoothly. Providing social support by listening to concerns of the patient and their family. So a goal for diabetes is not going to be the same for everybody. So maybe there's other big issues going on before they can even address the nutrition and diabetes, things like that. So just providing social support and listening to their priorities and what's important to them. Assist patients in obtaining home health devices to support self-management. So this would be if they needed something from their insurance, but they need to go through their doctor, they can help the patient advocate for whatever they need, whether it's a blood sugar monitor or a blood pressure cuff or any other kind of devices. They need to just be encouraged to ask, what is the process? What do I need to do? And, you know, how can I help? And then support individual goal setting by using motivational interviewing. So this would be asking permission. Is it okay if I help you with your diabetes plan? Or is it okay if I help you read a food label? And maybe on a scale of 0 to 10, where are you for really wanting to go get your labs done? Or where are you for wanting to change from, you know, all that soda to some water? So the big thing to remember though is they aren't really providing recommendations on specific diet advice. So the macronutrients, the protein, carbs, and fat, we're not asking people to say, okay, based on this, you know, study I read or this, you know, article I read, you should be getting 30% fat, 30%, you know, carbs, and maybe 40% or 30%, 40% protein. So we don't want to be prescribing diets here. And especially so if somebody says, well, you need to eat a lot of greens because that's good for your diabetes and fiber, but then that person may be on Coumadin or Warfarin, and they really can't have a lot of vitamin K, or at least they need to keep their vitamin K consistent. So they really need to know that kind of stuff. So we don't expect community health workers to know that, just sort of supporting their goals. Excuse me. My role at the health plan, so I am the health coach for nutrition and diabetes education. So my role has changed a little bit. I used to work in clinics and hospitals, and I really did a lot of the decision making for, I assist the doctors in medications with how much insulin and what might come next. But now my role at the insurance company is really to encourage the member to ask questions and to make sure they understand how to take their medication and how to store their medication and what the numbers mean, what their blood sugar numbers mean. And also to connect them with community resources. So I coordinate diabetes care for members by providing community resources, so food pantries, WIC clinics, CSFP programs, different things in the community. I do assist the nurse case managers too with questions, like I said before. One other thing I haven't really mentioned is I collaborate with the community partners and stakeholders. So right now we have a collaboration with the YMCA in Manchester, and we're working on getting people into the program for diabetes prevention, and that's going really well. I make sure the members know exactly what the class entails, and it's a very big commitment. So we make sure they're able to either attend in person or they do a virtual version, which has been going well. So that's one community partner that we work with. Another one we recently started working with is Lamprey Healthcare. So one of the diabetes educators reached out, and we're gonna just kind of be a good resource for them, and they're gonna be a resource for us. And some of my responsibilities to get more specific at the health plan is I listen to members with compassion and give support for their concerns. I might say things like, how does that make you feel? Or what's most important to you to do at this time? Out of these 5 things that are important, what's the most important to you, and what's the most doable? So they may really want to ride their bike, but they don't have a bike or they don't have sneakers. So that might not be really doable, but maybe starting to do some home exercises in their home might be more doable to get ready for that bigger goal. So I also allow members to confide in me while maintaining confidentiality and professional ethics. I can't say enough about how important it is to be to hold that confidentiality and abide by HIPAA. I just think it's really important. When I see somebody in the community that I've worked with, I won't usually make eye contact and say hello, but if they do first, I will say hello. But we cannot be, sort of friends with our patients and members outside of our work. And then I guide members with a lot of motivational interviewing skills to be advocates for their own health. So I really try hard to get them to be making their own decisions and helping them with advice as far as, they might want advice on certain things like nutrition, but I let them be in the driver's seat as to which one they're going to start first. So if there's limiting sodium, limiting saturated fat, eating more fiber, counting carbs, lowering your portions, I might say, which one of those do you see really doable in the next week or two? And then I support them in ways they can do that. One thing I do run here is a health coaching program for diabetes. So I try to review the 9 content areas set by the American Diabetes Association. And these topics are usually presented in class form, and I've seen them presented in anywhere from a 3-hour class to an 8-hour class. So this education is what I try to give so that these people can go out and what they call self-manage their diabetes. So they're still going to their doctor, but they know more about all of these areas so that when they go to their doctor, they can be more prepared to ask questions. So, and when I talk to them on the phone, I'm giving them more of an individualized approach for each of these sections. So nutrition, I'd go over basic carb counting, and they don't even need to carb count. They could just do portion control. If they can't carb count and read labels, that's okay. I usually tell them a handful of carbs is about 15 grams or a half a cup. So they can, decide how many of those they can have in their meal. And I'll go over some basic other stuff too, like where's the sugar coming from, or maybe they're skipping meals. So general kind of nutrition things related to their health. And exercise, I won't really give an exercise prescription, but I will say, did you know that 10 minutes of exercise after a meal can actually start dropping your blood sugar pretty quickly? So they don't need to exercise for an hour and risk hurting themselves if they're not physically fit and appropriate for exercise. So I might just say, check with your doctor, make sure there's certain things you can do, and we'll take it from there. People with eye disease or retinopathy problems, they usually can't do a lot of exercises that would put strain on the eyes. So we wouldn't want them doing a lot of, bending over and stressing their eyes, because it can cause some more problems. Monitoring, I go over, do you have a meter? Do you know how to use your meter? And how often are you checking your sugar? And do you know what those numbers even mean? Many people are just testing and they don't even know what the numbers mean. So I'll go by the American Diabetes Association guidelines, and that is less than 130 if it's before meals or empty stomach or fasting. If it's 2 hours after a meal, they go by less than 180. So they can have a little jump in blood sugar after a meal, and then by the next meal, it should come back down to normal. And if they don't have a monitor, I'll let them know what we cover, and I'll encourage them to call their doctor. If I have to, I will help them call their doctor and do a 3-way call, but I encourage them to really do the asking and putting them in charge. And then medications, I make sure they know how to take their medications, what they do in the body. Some affect the liver, some affect the pancreas, some affect the kidneys. So I just make sure they understand. And I also ask, if you're on insulin, are how are you storing your insulin? The insulin they use, the one that they are, when you puncture the little red, the rubber top to the insulin, whether it's a vial or a pen, that is only good for about 28 days. And if it's a mixed insulin, it might only be good for 14 days. So out at room temperature. So all the other medications they have, I mean, insulin vials or pens that are not being used should be in the refrigerator. So I let them know, make sure they know that. If someone's homeless and they're carrying all 5 pens in their backpack and only using one, then those other 4 pens can actually go bad. So those are things too. They can also talk with their nurse educator at their clinic. Acute and chronic complications. Acute would be low blood sugar, high blood sugar, causes, symptoms, and treatment. So those are what I go over too. And then the chronic complications would be kidney disease, eye disease, foot problems, preventing any problems in the future. And usually those are all prevented or maintained through regular blood sugar control. With that, it goes into reducing risks. I encourage them to get their eye exam once a year, check their feet all the time at home, but when they go in for their official diabetes visit every 3 months, they can take off their socks and just show their doctor their feet, and then they can look for any problems. And smoking, we want to reduce risks for heart disease. So I just ask them, a whole bunch of questions. And psychosocial and behavior change, that would be, so if someone is struggling with a depression or anxiety or something, and or how can we get them to go from pre-contemplation to contemplation to preparation to action to maintenance. So I'm looking at those stages of change and trying to figure out what's going to make it happen for that person. So that takes, the health coaching program is 6 months. So within those 6 months, I cover all of those topics. I'm thinking more about education to members or patients by the community health worker. These are things I came up with, and there's certainly a lot more, but I tried to keep them food and nutrition and diabetes related. Saving money at the grocery store using leftovers. I put down buying a whole chicken or a turkey and making 3 or 4 meals from it instead of just buying the individual chicken breast, which might only make 1 meal. Buying the whole fruit or vegetable, so buy the whole watermelon, cut it up, because the ones that are cut up for you are going to cost more. And same with cantaloupe. I've seen lots of plastic containers with chopped carrots, peppers, onions, and you can do this on your own. The long, good old-fashioned carrots are actually cheaper than the little baby carrots. So yeah, you can encourage them to do that because it'll save money. Plain cereal with fiber can be a snack, dry with no milk, meaning if they have a ½ cup of Cheerios or ½ cup of Chex Mix, that could be a 15-gram serving for a person with diabetes. They can have milk, but I'm just thinking of a quick, easy snack that doesn't need refrigeration, and you can portion those out pretty easily. Making homemade gelatin or puddings, not buying the ones in the single serving cups. Just another idea. Get people back in the kitchen and cooking and doing good old-fashioned prep with their foods. And more education to members for nutrition and diabetes. Meal planning can actually be a big time saver and a money saver. Not shopping when you're hungry, shop for what is on sale that week at the store. Learning how to compare the foods using unit pricing on the shelf can be very valuable. Learning to keep a food journal or monitor how much and what are they eating. So that can really play a big role if they're trying to lose weight. There's been studies that show people who just track their food in the journal or even on the phone, electronic, apps, actually help people lose weight, and they're not really following any specific diet. More specific to diabetes, and I'm going through these quickly because I know we only have a certain amount of time, but feel free to save your questions and I can go back to these slides. Getting nutrients from food, from real food and not supplements. Those supplements are not regulated by the FDA, and so they may not have everything in them that they're saying. And no supplement can ever put all of the nutrients from a real blueberry or a real strawberry into a pill. Encouraging people to let the doctor know about these supplements. Fist-sized portions of each food can be a good rule of thumb for measuring out their portions. Another one is men and women have different fist sizes. So if you put your fist out, that's about your size for your carbs at your meal. So that for a woman making a fist, that's about 45 grams or 1 cup. For a man, that fist size is about 1.5 cups of carbs. So we're talking about carbs in that situation. Helping people find strategies to remember to take their medications and go to appointments with their doctors. This can be done with sticky notes, alarms on their phone, or even on the calendar. People can write their blood sugars on the calendar, or write, you know, time. This is when I'm supposed to take my insulin. They could also, taking insulin, they can put their nighttime insulin near their bedstand, because you take it at night and it doesn't have to be refrigerated. They can put their mealtime insulin pen in their silverware drawer because they need to get silverware to eat their meal. You could remind them they can have carbs, but not to eliminate them. They should be eating a little bit of carbs throughout the day. Reading food labels, but not giving an advice, you know, on macronutrients. Encouraging people to be active, but not recommending specific exercises, and to get cleared by their doctor to begin exercising, especially with diabetic retinopathy disease. So that's my presentation. And I can go back if anybody would like to, but if you need anything, my email is probably the quickest way to get a hold of me. And I do have a direct line with voicemail, and then there's my address. And the American Diabetes Association and the Association of Diabetes Care and Education Specialists are two organizations that do not promote ads with bars and shakes and, you know, marketing things. They are strictly educational for the patients and members that we work with. So there's a lot of cute little handouts there on different topics. Like I mentioned, those 9 topic areas. And they have a lot of good recipes too on their website. And that's it.
Thank you so much,
So
Tina. That was great.